Hello, and welcome to the Society of Critical Care Medicine's iCritical Care podcast. I'm your host, Dr. Margaret Parker. Today, I will be speaking with H. Michael Uche, MD, PhD, on how Montefiore Medical Center in the Bronx, New York, quickly converted a children's hospital to an adult COVID-19 hospital. Dr. Uche is professor of pediatrics, interim chief of the Division of Pediatric Critical Care Medicine, and medical director of the Pediatric Critical Care Unit at the Children's Hospital at Montefiore and the Pediatric Hospital for Albert Einstein College of Medicine in the Bronx, New York. Welcome, Mike. We're glad to have you here today.
Oh, thank you very much, Margaret.
Do you have any disclosures to report before we get started?
No disclosures at all.
Okay. Mike, we all are, of course, very well aware of the massive load on the healthcare system that COVID-19 has inflicted on us. Can you tell us the lead up to why converting your pediatric hospital to an adult COVID-19 hospital was necessary, and how did the hospital decide to make this conversion?
Well, I think that people saw that this was coming, that the number of admissions was rising, and when you look at the kinetics of the number of patients and how they increased, it's really startling. It was like one patient, then two patients, and four patients, and it really fulfilled this whole geometric progression of epidemiology, which we've learned from way back in a scary way. Our adult colleagues, I think, were facing this quite a bit earlier than we were, maybe a week or so before we were. And a couple of things happened. One is the governor of New York and the health commissioner mandated that every hospital double its ICU capacity. The baseline ICU capacity of Montefiore, not including pediatrics, is about 106 ICU beds. So they had to basically double that number of beds. And as well as with the rising increase in patients, they needed to double it. And they realized with this illness in particular, the chance of someone needing ICU care was extraordinarily high. We first, in pediatrics, as we were into March, and we first became aware of it, we knew something was happening, and we talked early on about increasing the age range for the PICU. And then on March 25th, I got a phone call in the evening saying, we got a 22-year-old out in a local hospital in a medical ICU. Can you take him? Because we're filled up from the adult ICUs were filled. And that started the roll, and that was our first one. And since that point, just from a critical care perspective, we've been averaging about 10 intubated adults, ranging from initially they're trying to keep patients between 21 and 30 with us, but quickly that expanded, and as of this morning, we actually have our oldest patients 59 in the PICU. Simultaneously, there needed to be increased bed capacity, and the decision was made to convert one of our pediatric floors to an entire adult COVID floor. So they converted a 38-bed med-surg pediatric floor to an adult floor, which instantaneously filled just with ER backlog. And the doctors who were tasked with covering that floor were our pediatric hospital medicine physicians, as well as our pediatric cardiologists, with some assistance of adult PAs. At similar time, we expanded the age on another floor from 21 to 30. So anyone from 21 to 30 would go to that floor, which was traditionally a pediatric floor, trying to keep our hem-onc floor stable and COVID-free. They then took our PACU in the Children's Hospital and converted that into an adult ICU, where it now still exists as an adult ICU. So it's been extraordinarily rapid and a real change in culture, which I'm happy to say the hospital staff has adapted to amazingly well.
Did you have issues with things like credentialing? You know, you've got a bunch of pediatric practitioners who are now taking care of adults. And how did you deal with the, I'm not credentialed to take care of adults question?
Yeah, That question is, of course, has come up on many occasions because we do take to 21 up in the Children's Hospital in general, as well as some of the subspecialty services tend to take hold of their older patients. So this question comes up from time to time, and we have discussed it before. For this particular case, they just decided to forego those rules. I think there were certain things in the state rules and what the public health law said about this that allowed them to forgive it. But there has been very little pushback, interestingly, from the pediatricians and certainly from the hospital for the pediatricians to cover these adults. For instance, on the adult patients on the pediatric floors, in order to help out, the adult consult services, all of the consults are actually first through the pediatric subspecialists and then discussed with the adult subspecialists afterwards. So everyone's learning a lot of adult medicine, but there hasn't been, to my knowledge at all, any administrative or legalistic pushback on that.
Well, that's great. And how about the comfort level of the both the nurses, physicians? Probably those are the two most, but potentially other healthcare team members in making this change, particularly as you get to, a little bit older adults.
Yeah, yeah. I think the circumstances change that. I've known, traditionally, if you think about our units, if we tried to admit an adult patient to our PICUs on in normal times, the amount of pushback would be astronomical. But in this situation, there's been very little pushback from anyone. The nurses have sort of taken it in stride. I'm really amazed, and certainly there was a ton of nervousness up front about it. What am I going to do with all these problems? I don't know how to do diabetes, hypertension, and everyone comes in with lots of problems. These are, your typical adult patients.
Yeah.
But people seem to have taken it. I'm really proud of the department and the pediatricians. And interestingly, they didn't really ask the medicine people to take care of kids, but they asked the pediatricians to take care of adults. And I think they've done a good job, and they've actually met what the real challenge is extremely well. So if you think about it, well, if it's hypertension, I can call someone and figure it out, or I can do that. But the real challenge is, particularly with this illness and how dynamic and fast changing it is, you've got to talk to people about end of life care. You've got to talk about goals of care. You got to talk about making people DNR, DNI, and it is it's a very different paradigm with adults than we deal with in kids, because in kids we're talking to parents, so we've learned how to do that. But it's different when you're talking to a 30-year-old adult, with two kids and a wife, and realizing that they're about to get intubated, they may not get extubated. So that has been, I think, a real challenge. I think the emotional toll of this is going to be tough because we in pediatrics do tend to be a little bit more sensitive to these things. We think. I don't want to say anything about our adult colleagues, but this is, we tend to be a little bit more on the sensitive side than some of our adult colleagues. So that has been a real challenge. The nurses have done a great job in the PICU. These patients, once they're intubated, we prone them for most of the day. Our adult critical care group is an extraordinarily ARDSNet and guideline-based group, and everyone gets proned. They believe strictly in ARDSNet and Prosiva, and their people get proned for 16 to 18 hours a day. And when you're proning a 150 kilo patient,
Yeah.
that is an enormous amount of work. And so we have these proning teams that are going around the unit twice a day and flipping these patients over. And it's amazing. And no one's complaining of, I'm sure it's all going to happen. No one's complaining of backaches and pains, and they realize it has to be done, and they do it. And it's outstanding.
Well, that's great. You mentioned obviously the challenge and the size of the patients. What other challenges did you have in accomplishing this switch?
Well, I think one of the big challenges, and in addition to a different medicine, dealing with the goals of care and end of life care, has been approaching emergencies. And these patients, for instance, on our one floor with 38 adult COVID patients, a number of them are on high flow nasal cannula and non-rebreather face masks. We're doing everything to maintain some degree of oxygenation in them. And they're often, and on a daily basis, there may be 1 to 2 patients intubated on that floor per day. And that is extraordinarily uncommon in our world of pediatrics. And yet people have had to adjust to that. And not only that, but you might have to adjust to intubating a patient on the floor and then not having an ICU bed available right away. So now we have patients that are intubated on a ventilator on a med surg floor staffed by pediatricians and pediatric specialists who can't go to an ICU for sometimes 5, 6, or 7 hours before a bed's identified. And that is that's a real paradigm shift in the way we practice in pediatrics. It was very interesting. I was talking to one of the nurses on the floor, and they go, "This is totally going to change the way we practice medicine." We call traditionally in pediatrics, we'd call a rapid response if someone had retractions and needed 25% oxygen. And now we're not calling a rapid response until someone's satting 88 on 60 liters of high flow. And so it's going to be, I'm a little bit worried what might happen come the fall or next winter when the lessons learned from this episode are taking effect. But that's been a challenge. But people, if we can find a way to support them and listen to their concerns, we've managed to deal with it for the most part. So if someone gets intubated on the pediatric floor, even though it has been done by the adult rapid response people, we will send a team from the PICU down to manage that patient until they can either come up to our unit or to the adult units as they open up a bed.
What do you do with the children who are in the hospital? It sounds like your pediatric floors might be sort of separate. You have this large adult unit, and the children presumably are on the pediatric units. But what about in the ICU?
Yeah, it's kind of mixed. I looked at the census this morning, and our youngest patient in the PICU is 2 months old, and our oldest is 59 years. So it's an incredible range. And you'll see adult, 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 baby, adult, adult, baby, child, teenage. It's
You
what's
just put them where you
what
have to.
exactly. We try, if possible, to sort of cohort the COVIDs in the unit in various places, but now you essentially have to assume that every single patient in the unit is COVID positive, and just working really, really hard to keep those sort of, those chronic trach vent patients that have been in the unit for a while, and you really, really don't want to get this, trying to keep them free of it. But there's a lot of juggling around. And the startling thing is, where did all the children go? And there just aren't that many children in the hospital. The true pediatric ED volume of the volume of children is way, way down. And most of the people that even our pediatric ED is seeing now are 21 to 30 years of age, all coming in with COVID-related illness. I think it's partially because they're out of school and they're not exposing each other to all the stuff kids expose each other to in school all the time.
I was just going to say that. Social distancing works for RSV.
Yes, absolutely. I think it's very, very true. And I think it works for asthma, and it works for all the viral triggers of asthma. I think the families are keeping closer eyes on them. The subspecialists are working hard to try to really minimize someone who comes in. Now, some people have to come in. You have your patients on, leukemia protocols that have to come in and need their spinal taps and bone marrows, and we're bringing them in very, very carefully. Most imaging is somewhat elective and can be put off, but some is urgent, and that has to be done. So our sedation service is still pretty busy, and you still get, the smattering of illnesses which can't really be taken care of outside the hospital that come in. But for the most part, the number of kids has really decreased that have been in the hospital.
What about staff illness and availability of PPE and so forth? That's been a huge topic in the news and throughout New York, especially.
Yeah, it certainly has. The staff illness is a real thing. A number of, I think the nursing staff is reporting that one quarter to one third of our PICU nursing staff is currently off, either quarantining or waiting for symptoms of COVID to go away. We've had a number of, in our division, which is 11 attendings, we've had 2 attendings out at the same time with COVID illness, one fellow out, and they're gradually coming back, thankfully. And there may be others going out. So it's been a real challenge to maintain staffing in the face of becoming ill, as well as trying to prepare for the eventuality that any one day someone may wake up with a fever of 102 and not be able to come to work. So that is tough. But so far we've managed to keep working, and we've tried to build in as much redundancy as possible. Since a number of most of the fellow staff in the department have been deployed to other sites within the hospital and care for patients, we were able to actually get a Peds EM fellow who we had trained and had rotated with us to spend a couple of weeks with us to augment us while one of our fellows was out. Plus, even in times of pandemic, normal things happen. People have to go home for personal reasons. There's family issues and things that may keep someone out of the hospital, and you have to accommodate for those. The PPE issue is it's very angst provoking. Mostly, I think, because of the huge unknown aspect of this disease. We see hospitals in Asia and Europe where people in the ICUs are in full, inclusive PPE with positive air pressure respirators, and then we see our own CDC guidelines that say, well, an N95 mask and a face shield and a gown should be sufficient. Or they also say that's the minimum necessary for this illness. And so there's sort of a little bit of distrust or uncertainty there. And there's like wide varieties as we've tried to garner PPE and make sure that we have adequate supplies. There's like different forms of masks and different forms of gowns, and that's changing on a day-to-day basis. And we're reusing face shields, reusing N95 masks, and I think it's less of an issue now than it was a week and a half to 2 weeks ago. I think there is more materials coming in, and I haven't heard as many sense of dissatisfaction as there has been in the past. So that's a little bit better. We're still not really sure what is the correct PPE for things like intubation or the really, really high aerosol generating procedures like that. And intubating these patients often is a very, very, there's a lot of stuff floating around by the time you intubate these patients. So that is certainly anxiety provoking. But I think it's better. And I think the hospital has really worked hard, as they all have, to try to maintain some adequate supplies. But you'll go around on a given day and there will be no gowns. And you're saying, I need a yellow gown or I need an isolation gown. And you're walking from bedside to bedside to find out who's got some. Or these are the number of face masks that we have, or this is the number of cleaning wipes that we have. This is what we have for the next 12 hours. Let's make it work. So you end up cutting the cleaning wipes in four parts or 2 parts to 4 parts in order to preserve them. It's been a challenge.
Things that you have to do in time of an emergency. And the issue of available ventilators has been out there. Has that been an issue for you?
I think we made it through. Um, Definitely, we had to go beyond what the hospital stock was, and we did get the state ventilators. I don't know if they're strictly state reserve or they were part of the national stockpile reserve, but we did get, and most patients or every other patient now who's intubated is put on an LTV, which is the state has provided. We try to be proportional in what people need. The LTV is somewhat limited in the amount of PEEP you can give. You're sort of limited at 20, and some of these patients do need more than 20. And but after a few days of being very frightened about there not being adequate ventilator supplies, it appears to be better now.
Yeah, it sounds like the curve is flattening.
Yes, it looks like it is. I think um, that I know the number of daily intubations has sort of flattened to decreased. I think the ICUs are still going to continue to be busy for a while yet because patients in the hospital are going to continue to get sick. Um, But between the LTVs, we've occasionally tried to intubate onto the V60 BiPAP machine. That doesn't work so good, but they've tried that. Um, and we've tried to maximally utilize. Interestingly, high flows have been in very short supply, and trying to put patients on high flow nasal cannula has created some issues as well. Um, but we, as a department and as a hospital, we did review the state ventilator allocation guidelines, and set up a triage committee and wrote our own guidelines. But fortunately, the governor never did declare a public health emergency, and we never did have to sort of make those horrible decisions about who gets a ventilator and who doesn't, or who gets taken off a ventilator so that someone else can go on. So we set up the mechanism to do it, but fortunately, we have not had to do it, and it looks like we won't have to.
That is such a relief. I have lived in fear of having to be the person to make that kind of decision, and so it's a relief that things look like they're easing back, and you won't be in that position.
One of the lucky things about, I don't want to say lucky, but one of New York actually had done a lot of work about thinking about this early on, and the state allocation document written by our current health commissioner is actually very robust and very, very helpful.
Right. Presumably, once this COVID-19 crisis resolves, or as the curve slowly decreases, you will eventually convert back to a children's hospital. How do you plan to do that?
That's a good question. I know in all disaster management, you're supposed to think about return to normalcy at the same time you're ramping up. I imagine what will happen is that eventually a number of the extra ICUs which have been set up in the medical center will be disbanded as capacity in the what they call the legacy ICUs returns. They'll be able to shut down on a number of those, including our PACU in the Children's Hospital, and including we built a brand new infusion suite for the hem-onc and the GI and the rheumatology group, and that is now an adult ICU as well. So eventually, those ICUs will disband. Those patients will move back to the normal ICUs. I'm sure eventually either we'll be able to discharge the patients in our unit, or their dispositions will become more clear, and then we'll try to get the adults out of the floors on the children's hospital and get ambulatory and elective procedures and surgeries going again. But it's going to be a big transition. I'm not sure what the new normal is going to look like. I don't think it's going to look like the old one. I think people are going to get very happy and comfortable with doing telemedicine doctor visits, and whether people are going to be willing to come to clinic visits when it could have been done by telemedicine, that may change things a lot. Not so much in the world of critical care at all, but certainly in the ambulatory specialties. So so we're hoping to have some return of normalcy soon, but I don't see it for weeks or even a month or two yet, maybe.
Can you talk about the lessons learned for our listeners? You kind of referred to that earlier, but talk about the lessons learned from all of this experience.
Well, I think that one personal lesson I learned is that very early on, people started saying, "Oh, as doctors, we should not round at the bedside. We should round at a distance. We should round in conference rooms and maintain social distancing." And very quickly, it was very easy to separate ourselves from the patient and the bedside nurses. And that created a little bit of uneasiness and unhappiness because we're really asking our bedside nurses and respiratory therapists to put themselves in harm's way for a lot of time during the day. And it was very easy for them to start feeling disrespected by the medical team who was sitting at a distance and sort of making these directions. So the instructions, and as well as a nurse would be in a room for an hour, get out of the room, and a resident would come up to that nurse and say, "Oh, that blood sample we just drew hemolyzed. Will you go in and draw another Chem 10? Or by the way, we decided to turn the vent rate down. Will you go in and turn the vent rate down?" And it's a big procedure to go into these rooms and getting dressed and undressed to go in. And that became a little source of friction. So we've really, really stressed, really working hard to make sure that there's integrity between the medical and nursing teams. And in some units, they can do it better. We can't, our computers at the bedside don't have cameras, don't have microphones. You can't really communicate effectively that way. I think that was one key lesson. Be very, very appreciative and sensitive to what we're asking people to do. So you got to really support the staff. I think it's been a lot of fun, and don't want to say that, it's a bit weird to say, but to work with our adult colleagues and to work closely with our adult colleagues and actually see, as a pediatric intensivist, to see how adult intensive care is practiced as in dealing with adults. There's some things to learn that we don't see as much. We don't truly see as much ARDS in children as adults intensivists see, and that's been interesting for us to see. Um, uh, CRRT, which I thought would be easy or straightforward in adult patients due to the size of blood vessels and things like that, has been a nightmare because of the hypercoagulability and the microangiopathy that COVID is giving. I think that was a surprise. Um, I've learned it's extremely important to keep the team together. And we're in our own division, we have Skype calls for the whole division 2 to 3 times per week. They're actually extremely well attended, and I can get many more people on a Skype call than I can ever get to a faculty meeting. So it may be the way of the future. And and because people are not coming in when they're not on duty, because of the people that are home sick, it's easy to get a little bit disconnected. And people do want to talk about what's going on in their lives and what's going on. And I think that's been very, very helpful. Um, you got to learn all about the LTV, which has been something. Um, I think that the cytokine storm picture that these patients are developing is fascinating. And we're still just we do not have it figured out at all yet. I think that another key thing to learn is you have to be adaptable. It is plans get made on a Monday morning, and by Monday afternoon, they're 180 degrees the opposite. And if you're too rigid about being willing to change these things, it can be a real problem. We've had some successes. We've managed to get some patients extubated and moved out of the unit and even discharged home. But we've also had some badness happen, and we've had some patients die, despite everything. And that has been tough for us. I think that our adult colleagues set up treatment protocols a little bit earlier than we did. And once our pediatric subspecialists got involved, it took a little while to catch up, but they are for sure. And just trying to figure out how to approach these patients systematically has been tough. So I think those are, some of the lessons. And of course, ultrasound can be very helpful in putting these lines into these patients. So I think those are my big lessons, I think.
I really have to commend you and your colleagues and all of the healthcare workers in New York and around the country who are caring for this very sick, very frightening, perhaps, population under circumstances that are not our usual. And you have the gratitude of everybody in the country for being willing to put yourselves at risk to take care of these very sick patients. Thank you.
Oh, you're welcome. It's been very special to be in the middle of this. I think it's funny. We sometimes really want, in one sense, to be in the midst of the big thing, and on the other hand, we say, I don't really want to be here, and I'm regretting what I wished for.
Yeah, be careful about that.
I know, be careful. And it's even, I was talking to one of my friends in Italy, and even in Italy, things were so, and hopefully this will be the way in the States too. That in Italy, some places were absolutely horrendous, like Milan and the north, but other
Yeah.
parts, fortunately, weren't as bad. And I think something else is that we're going to have to figure out what this disease does to children. It's not as benign as we've talked about, and has been talked about. There is stuff that goes on, but even most of the children we see are kids with other issues. They're not kids that are healthy kids off the street. But it's been a huge challenge. I think everyone's getting a little bit tired, but I think that people are still motivated, strong, and they're going. They keep on going.
Well, thank you very much for talking with us today and telling us your story and for all the work you do. Thank you, Mike.
You're very welcome, Margaret.
We have been talking today with Dr. H. Michael Uche from Montefiore Medical Center in the Bronx, New York, about how they converted their children's hospital to an adult COVID-19 hospital. This concludes another edition of the iCritical Care podcast. For the iCritical Care podcast, I'm Dr. Margaret Parker.
Margaret Parker, MD, MCCM, is Professor Emeritus of Pediatrics at Stony Brook University in New York. She is a former president of the Society of Critical Care Medicine. She is currently serving as Associate Editor of Critical Care Medicine and Senior Associate Editor of Pediatric Critical Care Medicine. Join or renew your membership with SCCM, the only multi-professional society dedicated exclusively to the advancement of critical care. Contact a customer service representative at 847-827-6888 or visit sccm.org/membership for more information. The iCritical Care podcast is the copyrighted material of the Society of Critical Care Medicine, and all rights are reserved. Statements of fact and opinion expressed in this podcast are those of authors and participants and do not imply an opinion or endorsement on the part of the Society of Critical Care Medicine, its officers, volunteers, or members, or that of the podcast commercial supporter.